Next, I'd like to invite Dr. Elizabeth Joseph, Madam. She needs no introduction. A passionate pediatric ophthalmologist, and she can be addressed as a superwoman in strabismus surgery in India today. She is a HOD and heads the pediatric ophthalmology department at Little Flower Hospital, Angamali. She has innumerable awards, papers, and she's an excellent teacher and a mentor, and she does simple as well as complex strabismus surgery in a flash. She still keeps her passion for her subject by having talks on all these 3 days in Drishti 2023, Thrissur. And over to you, dear madam, for your talk.
Thank you, Dr. Arya, for that very kind and wonderful words. Thanks. Now, I'll be talking on nystagmus surgery, when and how. See, nystagmus, all of us know, is just a repetitive to and fro involuntary eye movements initiated by slow drift of the eye away from the direction of the gaze. It could be congenital or acquired. Acquired is always a problem. It may be due to labyrinthine, vestibular, cerebellar causes, and then there is this, as Dr. Naina has already said, the convergence retraction type CSO. I think Dr. Rashmin Gandhi will talk about all those things. All these things, the acquired nystagmus is a problem. It has to be referred to the neurologist. Imaging is mandatory. Whereas congenital nystagmus or nystagmus in children come to the pediatric ophthalmologist, and we have to manage that. The most important of the nystagmus types in children, the most important one is the infantile nystagmus syndrome, which will include both the motor and the sensory. And then there is the manifest latent nystagmus or fusion maldevelopment nystagmus, which is usually associated with ESO deviations. These two conditions are potentially benign, and you may not need much of imaging, but the other two, like periodic alternating nystagmus, spasmus nutans, etc., has to be investigated for neurology problems. Coming to the treatment, first and foremost, you correct refractive error. If there is a refractive error, contact lenses are superior to spectacles, because when the eye moves because of the nystagmus, the contact lens will be well centered. Whereas a spectacle, the visual axis and the optical axis will not correlate, and hence contact lens is superior if there is a refractive error. If there is no refractive error, there is no point in giving contact lenses. And if there is a small abnormal head posture, can be corrected by prism, but not larger than 15 degrees. Botulinum toxin has got a role, but it has to be repeated. So it's not practical. Biofeedback, acupressure, etc. have no role at all, and these are not effective. The medical treatment also is not effective, not of much use. The surgical management is very useful. And nystagmus surgery, the most common indication is nystagmus with abnormal head posture. If the face turn is more than 20 degrees due to a null point in one of the eccentric gazes, then this is the most common condition which is amenable to surgery. And nystagmus without face turn, we can do surgery, but the results are not that great as the ones with abnormal head posture. Coming to the timing of nystagmus surgery, that is very important. In orthotropic patients with nystagmus, you wait at least 5 years of age, because the binocular system has to be developed well. Otherwise, the binocularity may not develop. So 5 years to about 9 or 12 years of age, you can do nystagmus. Even in adults, you can do nystagmus surgery, but it's always, you can remember that it is the school age children. That is the best time for nystagmus surgery. But if nystagmus is associated with an esotropia, like in Ciancia syndrome, we have to do an early surgery. Acquired nystagmus, most often we don't do any surgery, and if you want to do surgery, wait at least for 1 year. And pre-surgical evaluation, full ocular exam, neurological workup when needed. One thing is that you have to make sure that the null point is consistent. There is something called periodic alternating nystagmus, where the null point varies. In such cases, if you do nystagmus surgery, you are likely to fail. And the measurement of face turn has to be done by the goniometer. Nystagmogram is not mandatory, but it has got academic importance. This is how you measure the head posture of using a protractor and the scale. The scale is directed at the one arm may be directed at the visual axis and the other against the axis of the head. The angle between the two is the angle of the face turn. And this is how you do a video nystagmogram, where an infrared camera is placed in front of the patient's eye, and this is the stimulus generating area, and this is the record. This is the record. This is not mandatory, but if you have access, you can do it. This we did. We don't have the nystagmogram in ophthalmic department, but the ENT people have this, and so we did this from the ENT. And interpretation of the nystagmogram. You can have the slow phase, the numerical values, oblique, angle, etc. This is the nystagmogram of the right eye and the left eye. And coming to the nystagmus surgery. In nystagmus surgery with the face turn, when there is in those conditions, when the face is straight, the nystagmus is more and the vision is less. So they turn the face to one side and keep the eyes to some other state. So in this case, there is a null point in the right lateral gaze, that is in dextroversion. In this position, the nystagmus is dampened and vision is improved. So the patient keep the eyes in the lateral gaze, and the face will be turned to the opposite side. So the principle of the surgery is to shift this null point to the primary position, so that the patient do not need to have a face turn. And the first nystagmus surgery was described by Kirstenbaum, consists of recess resect of horizontal muscles, but he described only a 5 millimeter recess resect procedure, which was found to be not enough. And then there is the Anderson procedure, where he described only recession. For example, in this eye, recession of this medial rectus and recession of this lateral rectus, that is Anderson surgery. Now what we do is the combined Kirstenbaum-Anderson surgery. In the original Kirstenbaum, only 5 millimeter surgery was done, but Marshall Parks have modified it to produce this classic maximum procedure, which is the 5, 6, 7, 8 millimeters. For example, if the eye is deviated towards the right side like this, you do a recession of 7 millimeters of this lateral rectus, resection of this medial rectus 5 millimeters, recession of this medial rectus 5 millimeter, resection of this lateral rectus 8 millimeters. Now, one thing, how to decide which eye has to go for larger recession and resection, it's easier to remember this way, that each eye will receive an equal amount of surgery. Like 13 millimeters in equal amount in when the medial rectus surgery and lateral rectus surgery is totaled, it will be unequal. And lateral rectus surgery is always greater than medial rectus surgery, because medial rectus is a more powerful muscle, and maximum surgery for LR resection. So in this case, LR resection is 8 millimeters. And the other LR is 7 millimeters. So maximum surgery for LR resection the most. That's how we remember this. And up to 30%, 30 degrees of face turn, you can do the classic maximum. If there is more of face turn, more than 40%, you have to have augmented surgeries like 40% augmentation or 60% augmentation, whereby you do this large, 8.5, 9, 7 and larger surgeries, the same principle, so that a maximum of about 18 millimeters is done. See, just watch the video of this child. She has got only a 20-degree face turn. Now the child is reading the Snellen's chart with a small face turn, 20-degree face turn. This surgery, this child underwent only augmented Anderson procedure, where the right medial rectus was recessed 9 millimeters and left lateral rectus 12 millimeters recession. That is Anderson alone, because the face turn is small. And we took an video nystagmogram of this patient. This is the pre-operative video nystagmogram, and this is the post-operative. You can clearly see that the amplitude of nystagmus has come down. And see, this child has got a larger face turn. This child also sitting in my office and reading the Snellen's chart. The face turn is about 45 degree, and you can see the primary position nystagmus. You can see the primary position nystagmus. So this child needed a larger surgery. We did a 40% augmentation, where lateral rectus 9.8, medial rectus 8.4 of the right eye, and left eye medial rectus 7 and lateral rectus 11.5. And see, look at the post-op video. This one. See, again, the child is reading the Snellen's chart with almost the face straight, and looking at the nystagmus in the primary position, the amplitude has definitely come down. So what I want to give the message is that nystagmus surgery is effective and the patients are always happy. It is not 100% successful, but you get at least 60 to 80% success in these nystagmus surgeries, and most of the patients are happier. If the nystagmus is associated with a strabismus, see, this patient has got a face turn, and in the primary position right eye is divergent. Now the principle is, first you correct the nystagmus in the fixing eye and correct the strabismus in the strabismic eye as two stages, or you use an adjustable suture in the single stage. See this patient, the face turn, and after surgery, nystagmus surgery, you can see that the squint is corrected, the face turn is gone. In complex situations like face turn with a head tilt, with the face turn and a head tilt, then it is difficult. Then you can combine oblique muscles along with the horizontal, but that becomes a huge big surgery. Now the other option is to offset the horizontal. See this child with a huge head tilt and a face turn. So what I did is a supra placement of the right lateral rectus, infra placement of the right medial rectus, and in the left eye, supra placement of the medial rectus and infra placement of the lateral rectus, in addition to the recess resect procedure as per the Kirsten-Bohm, and we could get a good result. Some people will come with just chin up position due to vertical nystagmus, just chin up position, then that is easy to correct. Do inferior rectus, superior rectus of one eye, or do inferior oblique anterior transposition. What about nystagmus without a null point? Like in this child with albinism, these cases we usually do not do anything, but if you want to reduce the amplitude of nystagmus, some surgeries are there. One is making artificial divergence by doing a small MR recession. Other procedures are you just recess all four recti, chinotomy and attachment to the fascia, all these are described, but the chance of recurrence is there, chance of induced strabismus is there. Nystagmus blockade syndrome, patient presents with esotropia, and when you cover the other eye, there is a nystagmus in the primary position. Because of the nystagmus of the primary position, which is dampened by the convergence, patient presents with a convergent squint. This can be easily tackled by usual surgery for the convergent squint, but you have to increase the amount of surgery on the medial rectus. And coming to another condition in which I just finish in 1 minute time. CNCS syndrome is esotropia with an abduction nystagmus. You just watch the child, there is esodiviation and the abducting eye goes into nystagmus. This can be corrected by strabismus surgery by medial recession, but it's better to do a posterior fixation suture on the medial rectus. In these conditions, the squint will be corrected, the amplitude of nystagmus will become less. Probably the nystagmus may become latent. The manifest nystagmus may disappear, but is likely to persist throughout life. Complications of nystagmus surgery, not many. Probably success rate is a little low. Recurrence is possible. So you have to warn the patients that sometimes recurrence occurs in a few years' time. And consecutive strabismus we usually don't see. Thank you very much for patient hearing.
Thank you, ma'am. And you have seen the Superwoman in action. And she has discussed and done surgeries in a very, very easy manner.